Today is on 24th of March, we are going to celebrate World TB Day. I am Professor Rajendra Prasad, Director Medical Education and Head Department of Pulmonary Medicine, ERA's Lucknow Medical College, Lucknow. I have been former Director, VALLABH PATEL Chest Institute, Delhi, and former Professor and Head, Department of Pulmonary Medicine, King George Medical University, Lucknow. Today, on the occasion of World TB Day, I will talk to you about the recent changes in treatment of tuberculosis. These are my institutes where I have worked, like King George Medical University, Lucknow. This is the Institute of Medical Sciences, SAIFAI, when I was director. This is a Patel Chest Institute, Delhi, when I was also director. And currently, I'm working in this medical college, ERA's Lucknow Medical College and Hospital. My today's agenda for next 25 to 30 minutes would be what are the basic concepts in the treatment of tuberculosis? What are the updates in treatment of drug-sensitive and drug-resistant tuberculosis? And last few time for future of tuberculosis treatment. You see, I start my presentation with this lady who had tuberculosis. You'll agree with me that she had cavity in the chest X-ray. She has bilateral infiltrates. Sputum was positive. And she was diagnosed as a case of pulmonary tuberculosis. She was given anti-tubercular drug in effective doses and for right duration. And you know, patient in a second X-ray, after 2 months of treatment, her X-rays has improved. Clinically, she has also improved. She gained weight. And after completion of treatment, you know, she has completely disappeared about symptoms. She has improved, the sputum has become negative. Now, to me, it is TB has been cured. So what I say usually, that tuberculosis is almost curable, provided adequate treatment is prescribed, and it is not the prescription of the treatment, but it should be taken by the patients regularly. Then it is, to me, 100% curable disease. But it is very unfortunate. Last year, about 0.5 million deaths has occurred with tuberculosis in India. So about 5 lakh people died. Now, is it not a paradox? And if I analyze, time will not permit me to go into details, why this is happening. A disease which is curable, but so many people are dying. There are many factors, but some of them are poor quality care of TB patients. All the patients are not receiving a good quality and proper treatment. Sometimes poor quality of drugs may be responsible. Markets sometimes are flooded with poor quality drugs also. So that may be another reason. Suppose somebody has developed resistant tuberculosis, the education is so poor management of resistant tuberculosis, like use of too few drugs for a too short time, limited access and poor quality second-line drugs also, lack of quality lab support, and failure to assure adherence. So these are the major issues which have been worked out, why there are death in tuberculosis. Now, before I go to the treatment, I would like to share one change which has happened in case definition recently, and that is about the case definition. Initially we used to call it a sputum positive tuberculosis, sputum negative tuberculosis. But as far as case definition, now we have got two types of tuberculosis. I hope in every prescription it should be written like this. One is microbiologically confirmed tuberculosis. When I say this, what do I mean? Microbiologically confirmed means either TB is confirmed by bacteriology, that is sputum for acid fast bacillus, sputum culture for Mycobacterium tuberculosis, or by the molecular diagnostic methods like gene expert, line probe assays. So either by bacteriology or by molecular biology, if disease is confirmed, this is known as microbiologically confirmed tuberculosis. And the second definition is clinically diagnosed. When I say clinically diagnosed, rest of the TB, whenever we diagnose, they will all come into category of the clinically diagnosed. So I will take you an example. Suppose somebody has lymph node in the neck and you think it to be tuberculosis. What is usually done? You do a fine needle aspiration cytology or do a biopsy. Now, if the fine needle cytology and biopsy shows there is evidence of tuberculosis based on cytology or histology, and you have not been able to demonstrate either AFB or by the molecular methods, then it will be known as clinically diagnosed tuberculous lymphadenopathy. Suppose in that lymph node, in a smear you made, whatever FNAC, fine needle aspiration cytology you did, and you make a smear and it is suppose AFB positive, acid fast bacillus is positive, then it becomes a microbiologically confirmed tubercular lymphadenopathy. That is the difference. And otherwise, pulmonary, extrapulmonary remains the same. Another change in the, according to the history of ATT, when you used to say relapse, initially what we have been taught about relapse, new cases, relapse. So relapse means a person who has been cured of TB and gets the disease again. That was the exact definition of relapse. Now this relapse has been replaced with the recurrent TB. And there's another change. We initially used to call TB suspects. Now TB suspects have been now replaced with presumptive TB, because the civil society people, they objected about the word suspect. Suspect is a very dubious word. So this has been changed by WHO to presumptive TB. So this is the definition. Otherwise, cure, death, treatment completed remains the same. Now you have seen the death is occurring in tuberculosis because of the improper treatment. So let me talk today how to treat tuberculosis. And you know, when you treat tuberculosis, what is your aim? Your aim is first is to cure the patient, prevent the complications and death. That is the very important aim. Avoid relapse. Relapse means this word has been changed into recurrent TB. Reduce transmission potential to susceptible individual. It should not be able to transmit to the others. And limit emergence and spread of drug resistance. That is what a good treatment, aim of a good treatment. And there are basic principles which are always adhered when you treat tuberculosis. Usually we know if you are treating tuberculosis, there is no single drug therapy today. It is combination of drug. 2, 3, 4 drugs are combined according to situation. Drug should be given in a single dose, and drug should also be given in effective dose and for adequate duration. These are the basic rules while we treat tuberculosis. Another rule, basic concept is, you see that whenever you treat tuberculosis, if you can read these sentences, there was a standard of TB care in India that was made in 2014. And that one of the standards says, it has many standards, standards for diagnosis, standards for treatment. And one of the standards is any practitioner treating a patient of TB is assuming an important public health responsibility. And what you have to do to fulfill this public health responsibility? To fulfill this responsibility, the practitioner must not only prescribe adequate, appropriate regimen, but also be capable of assessing the adherence to that regimen. And if there is any problem in adherence, then doctor should be able to address the poor adherence, if at all there. By doing so, the provider will be able to ensure adherence to the regimen and until treatment is completed. That is one of the very important basic issues while you treat tuberculosis. So it is our duty. If we have prescribed for patients of tuberculosis, it is our duty. We have to make our patient compliant. He should adhere to the treatment to its completeness. That is another very important issue. And when you treat, how to monitor treatment? Usually, best method is to monitor is the bacteriological assessment, like sputum smear for AB. Molecular biology is not used for monitoring the progress of tuberculosis. Then there is radiological assessment. Maybe at the end of 2 months, as I have shown in the first case, you see that whether radiology, the lesions are digressing, the lesions are progressing. That you have to make clear. Then clinical assessment is also. You just see that patient fever, patient weight, loss of appetite, whether these things are improving. That is how we assess the treatment, progress of the treatment. People do ESR. To my understanding, it is unsatisfactory method to assess activity or progress. So ESR should ideally not be done. Even WHO has advised against it way back in 70s. But still I see many prescriptions, they have investigation of ESR because we have very other good methods to track the progress of the treatment. Another very important issue in tuberculosis today is the TB notification. Now, in India, 2012, India has made the compulsory. And so whenever you diagnose or treat tuberculosis, you are supposed to notify them. Now, with these basic rules, treatment now consists of, now there are only 2 types of treatment available as per recent guideline: treatment of drug-susceptible tuberculosis and treatment of drug-resistant tuberculosis. For drug-susceptible tuberculosis, the last guideline was updated in 2010 by WHO, where you find that new cases treatment and retreatment, category 1 and category 2, those have been abolished. Now it has been updated in 2017 by WHO, by European Respiratory Society. And that says that you have got only one regimen to treat all the patients of drug susceptible, whether he is a new case, whether he is a retreatment case, he has previously received the treatment. New case means patients of tuberculosis who has not received any treatment in the past or maximum received up to 4 weeks. And retreatment means patient who has received more than 4 weeks of treatment. So all 2 types of patients, if they are drug susceptible, if they are drug sensitive, there is only one regimen to prescribe. WHO has prescribed 4 drug regimen, as you see: INH, rifampicin, pyrazinamide, and ethambutol for initial 2 months, followed by 4 months of INH and rifampicin. Total duration is 6 months. Now, WHO has also advised that in countries where primary isoniazid resistance is high, then in a continuation phase, instead of 2 drugs, you have to prescribe the 3 drugs. That is, ethambutol, you have to add it. So standard. So for India, what we have decided is a type of the, for new cases, it is the initial 2 months, 4-drug therapy like rifampicin, isoniazid, ethambutol, and paragenamide. And then in a continuation phase for next 4 months, we have to prescribe 3 drugs, that is INH, rifampicin, and ethambutol. And total duration is being 6 months. Now there is in these continuation phase, that is 3-drug phase, in both new and previously treated cases, may be extended in certain forms of TB, like CNS TB, like skeletal TB, like disseminated tuberculosis. You might extend for 3 to 6 months more. So total duration may become about 9 months to 1 year, but this is a definite situation. As I said, that the official American Thoracic Society and other societies has a drugs sensitive TB treatment guideline, and they say apart from those situations, they also suggest when we treat clinically, in many other situations, we might have to extend the continuation phase, and especially patients who has cavity, who has positive culture at 2 months, who is active smoker, who has diabetes, who is underweight, who has HIV infection, or who has extensive disease on the chest. In these situations also, what sometimes we believe that we might extend treatment, instead of 6 months, we may go to the 9 months therapy. And the dose wise, there has been now usual, you have to calculate the dose, although the fixed dose combinations is preferred, but INH is calculated for adults in about 5 milligram per day, nikhil ka phone aa raha. Rifampicin 10 milligram per day, paragenamide 25 milligram per day, ethambutol 15 average milligram, and streptomycin, although it is not used nowadays. And for most of the time, dose is given in a fixed dose combination. So for Government of India has advised that all the patients will be divided into 5 weight bands: 25 to 34, 35 to 49, 50 to 64, and then more than 75 kg. So, and this accordingly, you have to prescribe 2, 3, 4, 5, 6 drugs. 2, 3, 4, 5, 6 drugs. So that is how we decide about the dose. Treatment of extrapulmonary TB, it is same as pulmonary TB, except in situations I have described that one has to prolong the continuation phase to 9 months. We have index TB guideline for all extrapulmonary tuberculosis. This was released in 2016 for the first time in India. If you are interested, you may go to this guideline. You may find the CTD website. So that was about the drug-sensitive tuberculosis. Now, as far as drug-resistant tuberculosis is concerned, there are many types of drug-resistant tuberculosis. Monoresistance means resistance to one first-line anti-TB drug, like isoniazid is most common. Polyresistance, resistance to more than one first-line anti-TB drug, other than isoniazid and rifampicin, that is MDR. And then we have multi-drug resistance to at least isoniazid and rifampicin. And then we have extensive drug resistant XDR TB, when apart from MDR TB, they are also resistant to second-line injectables and fluoroquinolone. That was the previous definition. It has been redefined recently. I'll just share with you. And then another term with the molecular diagnostics, we have rifampicin resistance, and this is taken as surrogate marker for MDR-TB. As I said previously, the new definition of pre-XDR and XDR-TB. Pre-XDR-TB means mycobacterium tuberculosis strains that has MDR-TB and are also resistant to any fluoroconazole. And in XDR-TB, TB caused by MTB strain that fulfills the definition of MDR-TB and also resistant to any fluoroquinolone and at least one additional group A drug like bedaquiline, and this is the latest definition of pre-XDR and XDR-TB. The latest guideline, from last 5 years, treatment guidelines have changed, and final SAFE has taken in 2019 and 2020. And depending on that, even India government has made the programmatic management of drug-resistant TB in India. It was released in March 2021. And this is the guideline of WHO. So there you have got 3 types of drug resistance. One is monoresistance, H or mono or polyresistance. And here also what you prescribe here is instead of H, you replace with leofloxacin. That is for INH monoresistance. And the doses are given. And so you have got 4 drugs from start to end. And usually this regimen is for 6 months, and it may be extended to 3 to 6 months in certain situations. Extended directly to 9 months in patients with extensive disease, uncontrolled comorbidities, extrapulmonary TB, if smear at the end of 4 months is positive, and can be extended up to 12 months in CNS, skeletal, and miliary. That is how isoniazid drug-resistant TB is treated. If there is a replacement sequence in this, if you cannot use leofloxacin, then you have to replace with moxi. If even moxi cannot be used or jet cannot be used, then replace with linezolid. And if both drugs cannot be used, then you have to replace with 2 drugs out of 3, that is linezolid, clofazimine, and cyclosporine. And in children, treatment remains the same. Now, as far as MDR-TB is concerned, we have shorter treatment regimen, we have longer treatment regimen. Shorter treatment regimen, there are 2 types of shorter treatment regimen. One is containing injection and another is all oral shorter regimen. In shorter regimen, it is for usually 9 to 11 months of MDR-TB. And this is intensive phase is for 4 to 6 months, where we use moxifloxacin high dose, pyrazinamide, ethambutol, clofazimine, injection kanamycin. Lately it was replaced with amikacin, ethionamide, and high dose INH. This is 7 drugs in the intensive phase. And then in a continuation phase for 5 months, so you use moxi high dose, pyrazinamide, ethambutol, and clofazimine. So total duration is 9 to 11 months. This is what we know as injectable shorter regimen, and it is a package of treatment. If any patient is not tolerating any drug or he is resistant to any of these drugs, then he will not receive shorter regimen. That is one very clear rule. And then I said oral bedaquiline regimen. In India, in this 24th March, we are going to replace injectable with all oral shorter bedaquiline containing regimen. And regimen then will be composed of 4 to 6 months of bedaquiline. Bedaquiline is to be given for 6 months. Leofloxacin, clofazimine, pyrazinamide, ethambutol, high dose INH, and ethionamide for intensive phase, and leofloxacin, clofazimine, pyrazinamide, ethambutol for continuation phase for 9 to 11 months. Duration remains the same. And you cannot give shorter MDR regimen to every MDR-TB patient. if there is a presence of fluoroquinolone resistance, if there is a presence of second line drug resistance, if they are presence of INH resistance, both CAT-G and INHA both together, then you cannot prescribe this regimen. Other exclusion criteria for shorter regimen: children less than 5 years, extensive disease, severe extrapulmonary disease, history of exposure to previous treatment with second line medicine, and intolerance to any of the drug or resistance to any of the drug, then you cannot use this. This is a dose wise, every dose has been in 4 weight bands, accordingly dose is decided. Now we have a longer treatment regimen. That was a shorter treatment regimen. This is a longer treatment. Now this is also known as longer all oral treatment regimen. Now for this you have to divide all the drugs have been divided into 3 groups. Now only 3 groups. Group A include all 3 medicines like levofloxacin or moxifloxacin, bedaquiline and linezolid. And you know, these groupings have been made based on their efficacy, based on their mortality ratio, and based on the adverse drug reaction. So best drug now today to treat drug-resistant tuberculosis is levo, bedaquiline and linezolid. Group A. Group B consists of clofazimine, they are repurposed drug, and cycloserine or terrorid. And then last group is group C drug. This is, you have to choose from first 2 groups, but if in first 2 group it is not possible to make complete regimen, then you add group C drug like ethambutol, delamanid, pyrazinamide, imipenem-celestine, amikacin, ethionamide, and PAS. This is how groups ATT drugs for drug-resistant TB is divided. And all oral longer regimen, what says as per WHO 2020 recommendations, how you make regimen? All 3 group A agents like levo, moxi, bedaquiline, linezolid, and at least 1 group B agent like clofazimine, cycloserine should be included to ensure that treatment starts with at least 4 anti-TB agents likely to be effective, and then 3 agents in a continuation phase. However, in India, the experts, luckily I happens to be part of this group, expert concurred to start at least all 5 drugs of group A and A and B and continue with the 4 drugs. So in India, we have started with 5 drugs and to continue with the 4 drugs. And this is the regimen for all oral longer regimen. 18 to 20 months of bedaquiline. Bedaquiline is for 6 months, even sometime maybe longer. Then levofloxacin, linezolid, clofazimine, and cycloserine. This is the regimen for MDR-TB is for 18 months, and for XDR-TB, it maybe go for 20 months. Then there is also a replacement sequence. Suppose you cannot use any group 1A or B drug, then there is a replacement sequence, and replacement sequence in India has been worked out to be delamanid, amikacin, pyrazinamide, thionamide, PAS, ethambutol, imipenem, amoxicillin. So what I'm trying to say, the only thing is that when group C drug is only used, when group 1 or 2, you cannot make regimen from group A and 1 or 2, A or B. Combined use of bedaquiline and delamanid in the regimen is recommended as an appropriate regimen. When appropriate regimen cannot be designed using IL-5 drug from group A and B. Delamanid and amikacin will not be started in the final 12 months of treatment. No replacement of any drug is dropped in final 12 months of treatment. Sometimes you may use bedaquiline and delamanid beyond 6 months if only 2 of the 5 available group A and B, an adequate number of group C drugs are not available. There are rules have been defined very clearly, and this is the doses again in the weight bands of all the drugs used in all oral longer regimen. There is another regimen which is known as BPAL, consists of bedaquiline, pitromanid, and linezolid. This is a regimen which is used, it is still not used regularly, but it is used in a passionate ground under operational research condition in India. And this is given to those patients of MDR-TB who are not tolerating drugs or XDR-TB, and this is for 9 months, and this effectiveness has been proven up to 90%. So I have come to the end of my presentation, and I said in the end I'll talk about what is going to be TB treatment in future. You know, you must have seen there are a large number of drugs on pipeline, new drugs. Large number of studies are being done. The first time we have dreamed to, can we reduce the duration of drug-sensitive tuberculosis? But now a paper has already been published in New England Journal of Medicine in 2021. 4 months of rifampicin regimen with or without moxifloxacin for tuberculosis. Now it is possible in this they have used 3 regimen, and I'll not go into details, but regimen is 8 weeks of rifampicin high dose, isoniazid, pyrazinamide, and moxi, and then 9 weeks of rifampicin, isoniazid, and moxi. This is about 4.5 months of treatment. So what do you mean to say? Probably now in future, it is still not being used, but paper is out, and in future, what we will be reducing the duration of treatment. And that has been our dream for many years. That seems to be becoming true now. And then you know that you have seen the BPAL group. We have all the GenX trial. Many trials are simply being performed where they are using 3 or 4 drugs. And I wrote an editorial in last year in Indian Journal of Chest Disease. Are we moving towards development of universal drug regimen for treatment of tuberculosis? Now probably yes. To my answer is yes. In future, we'll be having with all new drugs only one regimen which can be used for drug sensitive as well as for drug resistant tuberculosis. So in that direction we are moving. I think in next 5 years, you'll have universal regimen for all sorts of treatment of tuberculosis. With this, I have come to end of my presentation, and my concluding thoughts are, you know, if you are treating tuberculosis, treat them well, treat with full heart, ensure compliance, and use the proper regimen. For drug susceptible tuberculosis, I have already told you 4 drugs followed by 3 drugs. For all oral mono poly drug resistance, you have got this regimen, 4 drug regimen for 6 to 9 months. Then you have got shorter MDR regimen containing injections. You have got shorter MDR regimen containing all oral regimen containing bedaquiline without injection. And then we have all oral longer regimen, which I have already described. So choose, depending upon the situation. So what I'm trying to say, TB treatment has been made very easy. But then you have to be knowledgeable, you have to revise your, because all the guidelines have been changed. I think with these words, I must say before I say thank you, these lectures are also available on my YouTube. So you can subscribe on YouTube and can see my lectures. We have many books published on tuberculosis by JP Brothers, Manual of Tuberculosis, Clinical Tuberculosis. This is a textbook. Then this is the first MDR and XDR TB. And then a book on adverse drug reaction in TB treatment. And so with this, I thank you. I thank you all for very patient listening. Thank you very much. And if there will be any question, I'll love to answer those questions. Thank you very much.